Anca.
Here. My name
And Prashalini, I heard you. Sorry.
is
Maria Irina Di Vittorio
I'm
Ivan.
here.
Sorry, yes. Okay. Andrea Mara Angula. But Bianca is here, yeah?
Prezentă.
Monica Georgiana Roman.
Bună dimineața, prezentă.
Bună dimineața. Mihnea Stănciulescu.
Present.
Good. Okay. I
Excuse
have
me.
for you. Yeah, sorry. Who are you?
Suleiman Mohammed. You said I skipped
Yes,
yesterday.
yesterday. At the end of the middle of the lecture, you just disappeared.
I think it's another one. I was
Maybe.
until the end.
Really? Okay, maybe it was Laura. Okay, we forget about this.
No.
No, no one. Okay, I've noticed, but I cannot be a policeman.
Thank
Good. I will propose you like that to read some ECGs at the beginning. After that, to finish with few cases. Okay, and I will ask you one by one to be involved to read the ECG because it's important to know how to do it. Okay, I will start presentation. Actually, I start to put the ECGs and I wait for you to read it. 1 minute to do the job. Okay.
Doctor, I had connection problems. I just joined, but
You
I
are-
guess
You are
group 29.
no problem. One more. După 12. Bine. Do you see? Let's see.
Yes.
Okay, good. Let's start with the ECG. And if I remember correct, sorry. I have, okay, good. And I think that the okay is in line to answer. Estra, you are the learner. Okay. Take a look and try to describe me what. Let's try step by step. Okay.
Okay, so first I can see an ST diversion.
Start with heart rate and QRS axis and the rhythm, which is on this ECG. And after that, we describe what is wrong. It's possible. What about the rating?
Yeah, very fast.
Tachycardia. Now, usually under this tachycardia, what is below? Okay?
Yeah,
Good. But how it is? It's fast. I agree.
yeah. I think it's more than 130.
You have to know to calculate, and actually you divide 1500 to small blocks in as comes, and we seems to be about 70 small. Can I, how portrait? Yeah, I,
I think something like that.
if you find number to calculate, you could download it.
Okay. I think it's wider.
No, the QRS axis. It's like have to
Oh, yeah. Sorry.
start to learn about ECG because you don't know. It's obvious. Okay, I will go to the next one. Majid, tell me about the QRS axis. Do you hear me?
Hello,
Majid,
yes, doctor. Yes,
yes,
doctor.
okay.
Sorry.
Hala,
Yes. What was your question, please?
the question is, how is the QRS complex axis?
Um, is it wider than normal?
No, this is duration, but I mean axis, the orientation.
Um, uh, I'm sorry, I can't figure it
I
out.
will tell you the simple way. Probably most of you already know. The simple way is to compare the complex in lead 1 and with that in lead AVF. That means if it's positive in one of them and negative in the other one, and only from this very quick view, you can tell that it's deviated to the left. Okay, good. It's not good, but I hope you'll learn. Lorin Suleiman,
Oh,
tell me if you
Yes.
consider that it's a sinus split or not in this case.
It's sinus rhythm.
It is. You confirm, yes?
I can see the P wave in lead 2
Yes. Yes.
and the lead 3.
Yes. Actually, the most important leads for
Most of
yes,
us.
yes,
Yes,
for
the
seeing
lead
P
2.
waves are lead 2 and and V1. You take a look
Yes.
first of this one, these two leads, and after that you can tell usually if it's P wave or not. Okay, you are right. It's a sinus split, but about the general appearance, what is wrong with this ECG? Your colleagues already start to tell me, but I didn't let them.
About the white QRS complex?
Yes, but this wide complex, it's wider in the proximal part or the final part, just if you can tell.
In the first
Yes,
part?
yes, indeed, because it's a slower slope in the first part. And what do you think that explain this wideness of the QRS complex? It's in the first part, and if you take a look, if you think of the Greek letters, it seems alike with delta, with the letter.
So
Yes,
the WPW syndrome,
exactly,
Parkinson-White syndrome.
exactly. That's the diagnosis in this case. Actually,
Yeah.
this
Yeah, I see now the delta wave.
what?
Yeah, I see now the delta wave.
Yes. But in no other pathological ECG, you have the enlargement of the first part of QRS complex. Usually, it's the final part, and because of this enlargement of the first part, even the PR interval it's less than normal. If you take a look in lead 3, for instance, you see the complex is starting immediately after the P wave, or the lead 1. You see, it's not
Yeah.
between P wave and QRS complex. In lead 2, where you see well the P wave, actually the complex is starting earlier than we can see. It's an isoelectric part, because the complex will start in the same moment in every lead. And if you draw a line from the lead 1, you see that the complex will start uh, more proximal even in lead 2. Okay, good. We'll go to the next ECG. Let's see. 1 minute, 1 moment. Okay, let me take a look because I don't know. Good. Um, who is next? Muhammad. Suleiman Muhammad.
Yes.
You are there. Okay, but be active. It's not only important to be there, but try to be active. Tell me something about this ECG. If you have another one, start with the heart rate and with the rhythm and with the QRS axis. Can you tell me something about QRS axis or not?
Yes, 1 second, please.
Yes, no problem. Sorry.
Uh, it is left axis deviating.
Yes, you're right. You're right about this. Tell me about rhythm. It is sinus or not? What do you think?
No, I think it's not.
Why? Give me some hints, some reasons.
I can't see obvious POE.
Yes, we cannot see P waves. You're right. And the rhythm is regular or irregular? What do you think?
No, it's irregular.
It's regular? No, actually, it's not regular. Take a look
No,
to
irregular. I see.
irregular. Yes, you're right. If you're told like that, if you have told like that, you're right because it's irregular. Okay, it's irregular. You don't see obvious P waves. Indeed, it's not a sinus rhythm.
Yes.
What can be? What else can be? I'll not ask about the heart rate because we don't see the boxes.
Mm.
The QRS complex is narrow or wide?
Narrow.
Narrow. You're right. Do you see any atrial activity? You don't see, indeed, the P wave, but see something else between the complexes, which means atrial activity. Some smaller waves.
The ectopic beat.
No. I mean about not QRS complex in between two QRS complexes. If you can see something or see only a flat line, or you see one.
I can see several beats.
Yes. Do you know what that mean? What mean this atrial activity? There is indeed. I can tell you, it's atrial flutter. That means there are small waves which are sawtooth with sawtooth morphology, which you can see better in lead 2, 3, and AVF.
Yes.
Okay.
Okay. Thank you.
Not bad, but you have to improve.
Okay.
Yes. Okay. Let's go to the next one, and the next student, which is immediately Farah Yunis.
Yes, doctor.
Yes. Take a look to this ECG and tell me what's the problem with ECG. Tell me about the heart rate, the QRS axis, the rate, and what's pathological with this, if you know.
Yes, I'll try to.
Right.
First of all, it's a sinus rhythm,
Okay. Because there is a
a P wave followed by a QRS complex.
exactly. What else? Actually, the rate is not easy to be measured because we don't see well the boxes.
Yeah, because of the I don't see the squares.
Bradycardic. You cannot tell it exactly, but it's a little bit bradycardic. If you take a look to the first two, it's about, it's a little bit less than 50. Okay, tell me what else. Here's axis, and what's wrong with this?
It is deviated to the right
Why, you tell me?
because it is more positive on the AVF.
It's more positive, but
Point.
it's positive in lead one as well.
Yeah, it's
Normal quadrant.
normal.
Yes, it's normal quadrant. It's not deviated.
Yeah, it's not minus on lead one.
You have to compare these two.
Yeah.
Okay. And what's different? What is wrong? Because it's something very, very special on this ECG. Okay, I will go to the next student then. What
Yes,
you agree what your colleague Farah told?
I see the axis that it's normal.
Yes, indeed.
Phase one, it's equiphasic. So we look at AVF, the perpendicular one, and then we see that it's positive.
Nice, nice.
About 0.
Go on. Okay, that's good. But what about the street? It is sinus or not?
I can see that there is a STT elevation.
Okay, you're right. But tell answer to this question: it's sinus rhythm or not? What do you think?
It's a bradycardic sinus.
Bradycardic. Okay. Yes, but your colleague and you both are wrong a little bit. Even though there is a P wave before every complex, and it's a nice connection relationship, still the P wave has not the proper axis. That means it's negative in lead 2 where it's supposed to be positive, and it's positive in AVR where it's supposed to be negative to be a sinus rhythm. And that means it's an atrial rhythm. It's not sinus, actually, but it's not far away. Good. Tell me about the ST elevation, because it's very obvious.
Yeah, I can see it in lead 2, 3, and AVF. So we can see that there is inferior myocardial infarction.
Correctly. In which stage do you think? What?
Acute phase.
What?
In the acute phase.
Acute phase, indeed. It's acute phase, maybe even hyperacute phase, but it's real. What else do you see like ST, I don't know, changes in the rest of leads?
I can see in V2 there is a depression.
I don't see. I don't hear you very nice. Please speak louder a little bit. Okay.
Look, yes, we have to look for mirror image, and I can see in V2, and I can see depression also.
Yes, indeed. You have depression. What do you think that is the significance of this ST depression in V2?
It's a mirror image to be set in that in other leads is a primary STT elevation.
It's what? I don't get it. It's what?
It's a mirror image in order to know that's the
Mirror imaging, yes. No, actually not. Mirror imaging in inferior MI is in lead 1 and AVL, and actually it's present here. You can see very well, but there are other changes which are not mirror. For instance, this ST depression in lead in V2 is probably an indirect sign of posterior MI. Posterior MI is usually associated with inferior MI because its posterior wall is vascularized by the same artery, right coronary artery.
Yes.
Okay, what else? No, you don't have to know everything, but I just complete your knowledge because you know well usually. What about V6? What about V1? You didn't tell me anything about them. Do you hear me?
Yes, yes.
Okay, I will go to the next student. Okay, thank you. Is Kusai Zoabi?
Yes.
Yes. Kusai, tell me, what do you think about V1 and V6 in this ECG? How is the... Yes, tell me.
ST elevation.
Exactly, it's ST elevation. And what's the significance, if you know, the ST elevation in V6?
That we have a posterior myocardial infarction.
No.
Left myocardial infarction.
No, it's lateral myocardial infarction.
Ah, sorry. Lateral.
Usually V5 and V6, no problem. You are in the teaching period. At exam, if you don't know, you will have problem. But now you can allow to be without all the knowledges. Okay, you'll get it later. Okay, this means lateral infarction, and actually this infarction we call it infero-posterolateral infarction because ST depression V2 is because the posterior infarction, and ST elevation in V6 is because the lateral involvement. And actually, it's not a simple inferior infarction; it's a complex inferior infarction. Okay, no problem. You can tell me something about ST elevation in V1? It's a little bit difficult, but just ask.
What, like the super acute?
No, V1. It's ST elevated. You told me, but which is the significance of this ST elevation in V1?
Sorry, I can't hear.
You don't hear me?
Yes, repeat the question, please.
Okay. What is the significance of ST elevation in lead V1? If you know.
And like it tells us that we have a myocardial infarction at the interior wall of the heart.
Usually, yes, can be an anterior wall. It's a septal lead, but in this case, it's not. It's only a sign of right ventricular infarction. It's a little bit difficult for you, but still, if we have this case, it's good to know these things. Good. Okay, I will go to the next student, which is Elias Sabra. Wait a minute to prepare for you the ECG, the next one. Tell me about this, Elias.
So we can say that we have 3 boxes between 2 QRS, meaning we probably have a normal rhythm,
Normal
not
means
bradycardia, not tachycardia.
you mean about heart rate is normal.
Yeah, heart rate, sorry. And I think we have also a normal rhythm. I can see the P wave.
Normal is not a good word for
Sinus. Sorry.
sinus. Sinus, it's okay. Oh, sinus. Okay, so how do you?
Yeah.
No problem. I know that in your language you call it sinus.
Yeah. About the axis,
Yeah.
we can see in lead 1 it's positive,
Yeah.
and AVF it's negative. No, it's yeah, it's negative, I think.
It's negative. You're right.
So possible left axis deviation.
Agree. What else? What do you have more on this ECG? I agree more or less with what you told me.
And lead 1 I almost see like a normal QRS.
You like lead 1.
Yeah.
You don't like the rest of.
No.
I to
And
understand why it's like that.
I can see something wrong in lead 2 in the deep S wave. It's like a double S wave.
There is no that thing like double S wave.
Doesn't exist.
It's, no, it is like that. Can be notch on the S wave like in AVF, or can be Q small r and S wave like let's say in lead 2 more or less.
I can see a bit of ST elevation in lead 2 and 3.
Agree? Indeed. In AVF as well.
AVF as well, yeah.
And V6 as well.
Yeah.
Okay, what is your diagnosis? Okay, you have all the elements. Okay, I'll go to the next student. What about this ECG? Is missing Sahar Tatur? Sahar?
Yes, I'm here.
Okay, your colleague Elias told me at one point about this ECG, not bad, but still he didn't draw the conclusion. What is in this ECG?
I
What?
see in lead 2 and lead 3 and AVF the ST elevation, so it's
Good.
inferior myocardial infarction.
Which wall?
Lead 2, lead 3, and the AVF.
Yes, which wall of is infected? Yes, it's myocardial.
Inferior myocardial.
I agree, but what about the small ST elevation in V6?
V6. It's a lateral.
Exactly, it's an inferolateral myocardial infarction. But in which phase do you think is Sahar?
It's a superior acute.
No, it's not super acute. That was the last one, but this is not. It's subacute because you have only mild ST elevation, you have negative T waves.
Yes, sorry.
Yes, this is called subacute. No problem. Good. Okay, I will go to the next ECG and the next student. Just a minute to do this. Okay, which is Ahlam Wajid.
Yes, here.
Is not that nice, no? Okay, try with wisdom and without hurry up to try to read this ECG. Okay,
Okay.
you'll go like that to establish the heart rate and to check about the rhythm and the QRS axis.
For the heart rate, it's around 140.
Okay, yes, not bad.
And it's regular.
Irregular, yes?
Yes.
Yes, indeed.
And we have tachycardia.
Yes, because it's more than
100.
yes.
Okay. For the axis, it's left axis deviation.
You're right.
And for the QRS, it's wide.
Yes, indeed.
So
So, what's the diagnosis? Why is white this complex?
ventricular, I don't know, ventricular flutter or tachycardia.
You told me about ventricular flutter or tachycardia. Okay, I will tell you. Ventricular flutter, you don't see any waves. It's only
Only the ventricle.
like a sinus rhythm, not rhythm, sinus wave without any specific waves. This you can see very well waves. That is excluded to be ventricular flutter. About ventricular tachycardia, yes, you can think of this because it's a wide complex.
Yeah.
But ventricular tachycardia, it's regular. This is irregular. You told me that it's irregular. That you can look this. What else can be? Give me another explanation of wideness of the QRS, ratio of the QRS. If it's a bundle branch block,
Yes.
which one is its left bundle branch block or right bundle branch?
Left one.
Why?
Because in V1 we have an S, not R.
Agree. You're right. You're right. And you have to think like that. In most of the cases, a very irregular rhythm, like this one, explained by atrial fibrillation. Maybe it's very simple explanation. We have only atrial fibrillation with left bundle branch block. That's all.
Okay.
No problem. You manage well till one point. Very good. Let's see. Who's next? Ahlam. I will find for you an ECG. Even worse. Ahlam, you are there?
Yes, I already done.
Ah, you are scared. But I want from you to tell me exactly the heart rate, not only about.
$250.
Oh, no. 250, no, it's too much. Why? How you calculate it? How many blocks are between two consecutive
One box and a half.
no, a small box. We're speaking about small boxes.
5 and 8.
8, maybe, no, I think there's 7. Let's say, if there are 7, how is the heart rate? Or 8, tell me, but exactly.
214.
If there are 7, 214. Yes, you're right. Okay, it's better like that. Okay, what about the QRS axis?
It's a normal.
It's a normal quadrant.
Yes.
And the complex, it's narrow or wide? We have as well.
Narrow.
I mean, yes, it's a little bit enlarged, but it's not wide. The wide has to be more than 3 small boxes, and this is not about 2 boxes here. Okay, good. And what can be? It's regular or irregular. We have to define this.
It's irregular.
Irregular? Regular or I don't understand.
1 second.
You didn't decide.
It's regular.
It's regular, indeed.
Yes.
You have a regular, very fast rhythm, let's say 214, with narrow complex, what can be? Can be a sinus.
Here I can sinus.
Sinus can be. You don't see any P waves, but
No.
case maybe it's overlap with a T wave. But usually it's not a sinus rate. It's too fast for sinus rate.
Yes.
Else can be.
It can be here a ventricular tachycardia.
But ventricular tachycardia has to have a wide complex. This is
Narrow.
narrow. Okay, can be atrial fibrillation or not.
But we can't see the F wave here.
Yes, we don't see F waves. Indeed. Okay, we have to deal with this without F waves. It's atrial fibrillation or not? What do you think? A strong argument, a strong reason for being or not being atrial fibrillation.
In atrial fibrillation, we have the rhythm is irregular.
Correctly. This just rule out atrial fibrillation. Cannot be atrial fibrillation here. Because regular rhythm. Okay, not bad. I can tell you, it's a paroxystic supraventricular tachycardia here. Usually, the rate of this tachyarrhythmia is between 140 and 220, and this is in range for this. It's very regular with narrow complex like this one. It's not easy, but just I want you to think and to try to see all the important things. Very good.
Okay, thank you.
Right. Let's see which is next. Pasciolini,
Yes.
you told me that you are here. Okay, I have a present for you.
Yes. Mm-hmm. Okay. First, it's a regular rhythm.
Yes, indeed.
Roughly around 150 heart rate.
If would be 150, has to be two big boxes, but this is less than two big boxes.
So it's between 150 to
How much? Now try to calculate exactly that.
yeah.
You calculate how many, count it, how many small boxes are between two consecutive waves, and after that you divide.
It's seven.
What?
Seven small boxes.
Yes, maybe eight. Eight, I think.
Okay.
Eight. Divided 1,500 to eight. And you will tell me exactly how's the heart rate.
1,500. $187.
Okay, and if you check what is written on the paper, here you see that you are very close.
Yes.
Okay, good.
Axis, it's a
Yes.
normal axis deviation.
Mm-hmm.
And the QRS complex is quite wide. It's
It's not wide enough. It's
pretty
not wide.
small.
Smaller
Roughly
than
around.
three. It's almost three, but it's smaller a little bit than three small boxes.
Okay.
It's a little bit wide, but not enough. Yeah.
And the ST elevation in V1,
Yeah.
V2, and V3 as well.
How V3 is not. It's depression. V3.
Okay.
Okay. What do you think? What kind of rhythm do you have? What do you think?
It is not sinus rhythm. I can't see the SP wave.
Okay. Even sunscreen can reach this value in a very, very strenuous effort in young patients.
And
Mhm.
okay. So it's tachycardia.
Exactly. Yeah.
And ST elevation in V1, V2 may be
But
right.
can happen because of the very high rate. It happens sometimes, but it is indeed.
And lead 3, it has a RSR pattern, QRS complex in lead 3.
RS
R.
lead 3.
Yes.
No,
It's kind of M.
here now,
Yeah.
but it's not like that. To be S, a wave has to be below the isoelectric line here. This if only a notch here, we call it only a notch. If will be uh, R, and after that S, and another R will be R, S, R prime, but this is only a notch. A notch means a focal conduction problem in this case. Okay, I can tell you, it's the same disease like in your colleague. It's paroxysmal supraventricular tachycardia, and actually the treatment was like that. The patient received adenosine this is a Romanian drug, adenosine, and just convert it to the sinus wave. You see, this is sinus because we have P waves. This is prematral ventricular beat. But other, okay,
Okay.
that's the treatment of supraventricular tachycardia. Vagal stimulation or drug blockage of AV node, and this is one of the most used way of blocking the AV node with adenosine. Okay, good. Um, I will take another case. No, this I don't know this. Let's say this one.
Mhm.
Bianca, no, not for you, for the next one. Anna Maria Bianca. It's Anna Maria or Bianca?
Bianca is fine.
Bianca. Okay, Bianca. Just take a look and tell me about this ECG. After that, we'll discuss cases. You'll be the last victim.
Okay. I can see some waves with sinus rhythm.
Yes, just
one.
say by the rhythm and heart rate and QRS axis, and after that, what's wrong?
The rhythm seems irregular.
Yes, but it's yes. Where? You mean here?
In the first three leads, yeah, and the AV.
Yes.
The heart rate. The heart rate is I'm not exactly sure how to determine it.
Look at that.
Irregularity.
Distance between two consecutive beats, let's say here about 80, let's 18, sorry, 18 small boxes, and you divide 1,500 to 18, and you'll
83 beats.
Okay.
It's a normal axis.
Yes, it's a normal quadrant. It's more than 60 than 0. Oh. Okay. What else? What's wrong with this ECG?
In the V1 and V2, there's ST elevation.
Even in V5.
V5. In V5 and V6 as well, and V3.
Yes.
Which can indicate myocardial infarction.
Okay. In which wall of the left ventricle? Anterior, inferior, lateral, posterior?
Inferior?
No.
No? Okay. I'm not sure then.
Yes, but we have to be later sure about it.
Lateral, perhaps?
No, it's anterior infarction. And if you take a look to the lead 1 and AVL, you see that it's a mild, a minute ST elevation as well. That means it's an extended anterior infarction, which involve the high lateral leads. These are called high lateral leads as well. Okay. Which phase of disease is Bianca, this myocardial infarction?
Acute?
Yes, it's acute phase. Agree. Okay, this is maybe it's a little bit difficult, this one. Good. I will present you a few cases right now, and after that we'll discuss about these cases. Wait a minute to change things. Will be a stop. Okay, I'll present another case. I started yesterday, I continue today with these cases. It's a patient, rather younger for cardiac disease, which is smoker, and the patient has chest pain, which is severe because it's rest and exercise, and it's a little bit longer than usual, 5-10 minutes in the last month. And few days or weeks ago, the patient has a very dangerous malignant tachyarrhythmia, which is ventricular fibrillation. Usually patients are dying about this because of this, except the situation in which there is a bystander and has a defibrillator to do a DC shock. In this case, it was like that. And physical exam shows a normal clinical examination, except a systolic murmur in the mitral area, which is radiated axillary. What do you think was next? What do you think, Maria Irina Divan, that explained this murmur?
Can you repeat the question?
Maria or Irina, how to call you?
Maria.
Maria, okay. We talking about this murmur, which is a systolic murmur in the mitral area and radiates towards axilla. What do you think that can explain this murmur? Which valvular disease will manifest it like that? There's a valvular problem. Which valvular disease has this kind of auscultation? It's a hollow systolic murmur, I can tell you. You don't have any idea?
Insufficiency?
What insufficiency? Which valve insufficiency?
A mitral, if it's in the mitral area.
Yes, it's easy because mitral. Yes, it's mitral insufficiency, and we call it mostly regurgitation. Okay, good. What do you know about the etiology of mitral regurgitation? There are a lot of disease which can produce this. Tell me one of them, at least.
What is produced by mitral regurgitation?
What?
Mitral prolapse.
Yes. What etiology? Mitral valve prolapse. Yes, indeed. Actually, this patient has exactly mitral valve prolapse. Can you tell me another cause of mitral regurgitation?
Rheumatic heart disease.
Rheumatic heart disease, indeed. Yes, it's frequent. Very good. Okay, I will go to the next colleague, which is Andrea Mara Frangula.
Yes.
And ask for you, Mara, or Andrea, I don't know.
Mara.
Mara, how you prefer, to tell me another 2-3 causes of mitral regurgitation. If you we already know from Maria about prolapse mitral valve prolapse and the rheumatic heart disease. What
Endocarditis.
endocarditis? Do you know how happened what is the mechanism of mitral regurgitation in endocarditis?
Not really.
Usually it's a perforation of the valve, like, when you perforate a paper for put it in the file, around the hole, that's what happened. It's a destruction in a round area. Okay, good. Endocarditis, tell me something more, something else.
Relating this case, or relating this case, I
No,
don't understand.
no, not relating, generally speaking.
It's an inflammatory disease.
Inflammatory disease, which kind of inflammatory disease?
It's caused by bacteria usually.
I don't get it. Inflammatory disease? You don't speak about endocarditis right now, no? You have to speak about
It's an inflammation of
inflammation. Okay, inflammation, but usually it's not caused by bacteria. There are some conjunctive tissue diseases which can give this, like lupus or yes, rheumatoid arthritis, something like that. Okay, can be a cause as well. Can you tell me something more or not?
I don't think so.
Okay, I will ask one Alexandra Mladin. Maybe she has some ideas, supplementary ideas about mitral regurgitation etiology. Wanna?
Maybe cardiomyopathy.
Yes, which kind of cardiomyopathy? It's not bad, it's good. Actually, there are two mechanisms, and I want to know from which one do you think?
Hypertrophic.
Yes, there is a special mechanism in hypertrophic cardiomyopathy in which the anterior leaflet of the mitral valve is attracted towards the ejection tract and open during systole the mitral valve. Indeed, yes. But can be in dilated cardiomyopathy as well. But you know the mechanism in dilated cardiomyopathy?
No.
It's only the enlargement of the left ventricle which enlarge the mitral annulus as well, and the valves will not reach each other, and there remain a hole in the middle, and this is the mechanism. Okay, what else? Do you have other ideas?
Maybe it's congenital.
Congenital, yes, can be. Usually we speak congenital about the mitral valve prolapse, but other kinds can be rare. Actually, there is a kind of congenital which is more frequently. It is associated with atrial septal defect, primum septal defect. It's a split of the anterior mitral valve. Yes, can be. Good. Let's ask Monica Georgiana Roman. Maybe she will add something, but it's more and more difficult because everything easy was already taken.
Yes, I'm thinking of some medical treatment, maybe.
Medical treatment. Be more precise. You know that the doctors can be very evil, but I want to know exactly how to do mitral regurgitation to my patients.
I don't know exactly what medications, but I was thinking of that it can be a cause or from
And after
trauma.
that, now actually medication is not good for this. But some medical treatments can be responsible for this. For instance, but not with drugs. Some intervention. For instance, if the patient has mitral stenosis and we do balloon valvuloplasty for this, that means not the real operation, only put it from the veins, a balloon, and dilate the mitral valve. One complication of this intervention can be mitral regurgitation. Okay.
Okay.
Good. Tell me another etiology, if you know.
Collagen vascular disease.
Yes, but it's already taken.
Flail leaflet.
How much? How leaflet? How flail leaflet?
Yes.
But, yes, it's actually, you can tell me like that, but also it's not a complete answer because it is a rupture of a chordae. A rupture of the chordae in this patient can cause mitral regurgitation, and this rupture can be during endocarditis or by trauma, or sometimes you don't know why. Okay, can be. Okay, let's put Michna to find the gold in the sand. I mean, to invent some causes that were not said till now. Michna,
I was thinking of, for instance, atrial fibrillation can be a cause, or MI.
Atrial fibrillation usually it's a consequence of mitral regurgitation. It's not a cause of mitral regurgitation. What about MI?
I was thinking due to the necrosis, it can lead to
exactly this
insufficiency.
Not said before, even though I told you yesterday at the mechanical complication of myocardial infarction. Is this one of the complications? Yes, indeed, can be. But most of the time, the mechanism of ischemic, let's say, mitral regurgitation is not the papillary muscle rupture, which is very rare and very severe, but mainly the problem is with the wall on which the papillary muscle is inserted, and this wall becomes akinetic and didn't participate to the I don't know how to say in English, to the closure of the mitral valve. And this is the main mechanism. Because of the inferior wall, usually it's associated inferior MI, inferior wall, which is not contracted, and the valve actually didn't reach the other valve, and the orifice stay open. Yeah, okay. Ischemic is important, and you put it well. I think we managed to discuss about most of the etiologies in this disease. Let's try to continue the presentation. This is the patient. Okay, investigation, ECG was normal, echo, mild mitral regurgitation, biology, no necrosis marker, and we go to, and this is ECG. ECG is normal. Nothing special to be told about this ECG. But the patient has indication for coronary angiography. But waiting for this coronary angiography, the patient has chest pain. And during the chest pain, the ECG was like that, and immediately after like that. And a little bit more after time after the episode was like that. What do you think, Michna, is the case here?
Just a second.
Yes, of course, it's not easy.
So during the chest pain, we can definitely see the ST elevation.
Indeed.
In V1 to V4.
That means
So in pteroseptal
exactly.
sufferance, I would say.
Yes, you're right. You're right. And immediately it's like that. It's only an intermediary form, only to show you that the trace will not normalize immediately, but take a while, few minutes, or 10 minutes per hour to go to the normal ECG, which was recorded, let's say, 20 minutes after the chest pain. What do you think that is the case in this patient which have transient ST elevation during chest pain? Which is a diagnosis?
We can think of a spasm, maybe.
Yes, indeed. It's a spasm. Usually when you see in the emergency room this kind of trace, the ECG, you diagnose an acute myocardial infarction. But if this will go away in a few minutes and will become like that without any problem, probably the diagnosis will be spasm. And actually, the patient has during angiography a spasm on this point, which was relieved by nitroglycerin, and the other actually were normal. Yeah. And I want you to summarize again Prince Metal's angina, which is a rest angina and has typically transient ST segment elevation, but during this ischemia period, which is very severe, the patient can have arrhythmias or AV block mechanism. We told them treatment for acute episode, sublingual nitroglycerin is the best treatment. For prevention, calcium blockers, but usually you have to avoid beta blockers. And I'll show some other case with Prince metals with as well as the elevation in anterior wall with an intermediary phase like that, and after a few days with ST elevation in inferior wall. It's not a nice ECG, but still you can see that it leads 2, 3, and AVF. Where is AVF? Ah, this is AVF. Lead 2, 3, and AVF have ST elevation, and the rest of them no. And after a while, the ECG is coming to normal. This is Prince metals. Okay, I will tell you about another reason of myocardial ischemia. Another patient, a patient which is 72 years old with high blood pressure, hypercholesterolemia, previous smoker, which was admitted all the time. You discuss about the reason of admission. For class 3 angina, this is CCS, is Canadian Cardiovascular Society, which issued this classification. This angina worsened in the last months, and from the history, the patient has a triple vessel disease treated with coronary artery bypass graft 5 years ago, internal mammary artery to LAD, and saphenous vein graft to marginal. But after that, he underwent 2 times PCIs. This is percutaneous coronary intervention, PCI, for right coronary artery problems, first time, and after that for a problem in the saphenous graft marginal to marginal. Now, the physical exam, he has some minor things, but which are significant. That means non-equal blood pressure in two arms, which with low blood pressure in the left arm, and bilateral systolic murmur in the supraclavicular areas. And I want to show you how about these these graphs. And these are two drawings. One is with ascending aorta. Ascending aorta is still the arch where these collaterals are. Ascending aorta, which have two venous grafts, one to marginal here, and the other one to right coronary. You see these are on posterior wall of the heart. And for LAD, which is this one, it's an arterial graft with left internal mammary artery. And this is more or less the same with this internal mammary artery graft on LAD with the venous graft to right coronary artery, but in this case, they took the radial artery and constructed a graft with the radial artery from the ascending aorta till circumflex or marginal. Okay, this is a scheme. You see the left internal mammary artery is coming from subclavian artery. Usually it's used the left one. Sometimes it can be used the right one as well, but it's a longer distance and sometimes didn't reach the heart. Okay. In this patient, the suspicion was a left subclavian artery stenosis because the murmur, which was in the supraclavicular area, and the difference in blood pressure between left and right arm, and the chest pain. Okay, and we can show this by different anatomic methods like echography, invasive angiography, or computed tomography angiography. Or we can see if this stenosis has a consequence, and we do a specific functional test. That means only to exercise with the left arm and to see what happened. And actually, the echo was done here, and there is a stenosis, 70-75% stenosis, with an increased velocity, speed of the blood. That means show that it's a stenosis. And these functional arm tests show that the patient has chest pain, and the ST changes are very clear for sufferance of myocardial ischemia. You see ST depressed, which in this case was secondary to hypertrophy because it's with concavity. And here's more or less horizontally, and this is typical for primary or mixed ST changes because of ischemia. And angiography was done. You see, these are the clips after the intervention, standard clips, and this is the stenosis of left subclavian artery, and this actually is the mammary artery. And because of this stenosis, which was not present at the intervention, the operation moment 5 years ago, the anterior wall, which is fed by mammary artery, is ischemic. And actually, we treat ischemia, myocardial ischemia, by treating the subclavian artery stenosis by angioplasty and stent. And the result was well. The patient has no chest pain after that. Okay, let me tell about other patient. Is 57 years old man with no risk factors, which was admitted in the hospital for class 3 angina in the last 2 months. And actually, he was hospitalized 3 months ago in a neurology department because of dyspnea and coma in the first place, and needed mechanical ventilation for 1 or 2 days. And after that, after a while, they diagnosed the anterior myocardial infarction with LV dysfunction. And because of the delay in diagnosis, was not some kind of reperfusion done. But the patient still has angina. And there are some atypical presentation in myocardial infarction. And I want to ask you if somebody of you knows some kind of atypical presentation myocardial infarction. I wait for you to tell me, to propose some atypical presentation. This is about in 20% of all patients with myocardial infarction.
Not having like angina, like chest pain and
Yes.
stuff.
This is the base. Don't have angina or to have atypical pain, not chest pain. This, but what else? Can you imagine? Can you tell me something? I will tell you because I don't see your enthusiasm. Come on.
Maybe symptoms that aren't normally seen with STEMIs, like coughing or something like that.
Is not usually in STEMI, only when it's associated with heart failure association. Yes, can happen, but it's not a typical signs of myocardial infarction. No, it's not frequent, but can happen. Why not? What else? I put it your list here. Oh, sorry. It's not immediately. It's not valid. Okay. A lot of patients can be completely asymptomatic. And actually, you see after a while, after years, that the patient has a Q wave on his ECG, but he didn't recall any moment in which he had the myocardial infarction. Or sometimes the patient can have nausea or vomiting. Do you know in which localization of the myocardial infarction is more frequent to have nausea or vomiting? Who knows?
Inferior wall?
Yes, inferior wall indeed, because inferior wall is it's close to the diaphragm where the vague nerve, how we call it, vagal nerve is located, and for this association, this proximity can have these kind of symptoms, or heart failure without chest pain, or atypical pain. Usually this atypical means the site in which chest pain radiates, but sometimes the chest pain will not be present, only the radiation, and the patient has a very strong elbow pain or something like that, and he imagined that has a rheumatic disease, but it's not the case. Syncope. Syncope, it appears when there is a complication, can be AV block or tachyarrhythmias, which decrease the cardiac output and then the cerebral output, and this results in syncope. Do you know which kind of myocardial infarction is associated with conduction problem? Is more frequent associated with conduction problem? Who knows?
A septal, right?
No, no. Even though, yes, there is a conduction system, I understand why you mean this, but no, usually it's very well vascularized. It's not happened to have AV block, but sometimes happened, and it's a very, very big myocardial infarction in those cases. But the most frequent infarction in which there are associated AV blocks is inferior infarction, because inferior is giving the blood for AV nodes, for instance, and there is a temporary AV block. Usually it's transitory. Usually it goes away. It recover in few days till 1 week. Sometimes, rarely, there is a need for pacemaker, but usually not. Sometimes the patient can have some psychotic manic episodes, but this I don't know. I don't see any patient. Only I read in papers this. And systemic embolism. Usually when it's systemic embolism, it's like in the case that I presented yesterday with a LV aneurysm, which usually has a thrombus inside, and from this thrombus are sent emboli, which can occlude other arteries, usually CVA, cerebrovascular accident, or acute peripheral ischemia. Okay, this is ECG, and I want from you to tell me about this. What do you think is here? Okay, I will tell you because I see.
Button branch block.
What? Left band branch block. Okay, there is a blockage here, but it's not a left band branch block. One, maybe it's not wide enough. The other one is that, look here, it's narrow. The other one is actually myocardial infarction, and mainly it's a notch here and here. Only this is QRS aspect. Is a notched S wave, QS wave, and this is the sign on the previous myocardial infarction, which happened 3 months ago. Okay, and we send the patient to the coronary angiography, and the patient has this severe stenosis here, which was treated by a stent, and this is the final result. But this patient has to be treated by angioplasty or not, because already is outside the time window. Is after 3 months, and all the time there is these determinants established by Notter Reimer in 1979 or something like that, which determine how big is the myocardial infarction. One is the site of coronary occlusion. The most proximal the occlusion is, the bigger the myocardial infarction size will be. Time to opening the vessel, if is open, and this time usually has a window of 12 hours. It is not very fixed, but more or less 12 hours, in which there is a benefit of saving muscle by opening the vessel. If it's later, you cannot save the vessel, and the presence of collateral circulation. If collateral circulation are very developed, like in patients which used to have angina for a long period, usually the occlusion of the vessel will not result in a big myocardial infarction. In a small one, or sometimes no myocardial infarction, even with the closure of the vessel. Hey, in this case, do you think it's still useful to do angioplasty? Yes, do. Must do. What do you think? Your opinion? Because we are at 3 months after myocardial infarction. The bad thing already happened. The patient has LV dysfunction, ejection fraction 35%. Why we did angioplasty for this patient? Hmm?
The patient still has pain, so
Okay, very good. That's the answer. The patient still has pain. If there is only scar, will not be pain. If there is still viable myocardium, can be pain with this tight stenosis. And actually, after the angioplasty, the patient has no more chest pain. Yes, very good. We'll discuss about other patient. I think will be probably the last one. Who knows? It's a 51 years old man. You see, most of my patients were younger for cardiac problems with hypercholesterolemia and obesity. Was admitted for class 2 NYHA dyspnea in the last 6 months, and chest pain with back irradiation. And 3 weeks ago was considered that he probably has a myocardial infarction because of LV dysfunction and necrosis marker, but those were only moderate increased. That means not very specific. In a clinical exam, the patient has normal blood pressure and heart rate, but has two murmurs. One is a systolic murmur, the third intercostal space, and the other one is a diastolic murmur with a descrescendo fashion in the fourth intercostal space. Okay, what about dyspnea? You know very well this NYHA classification, but I'll put it again. And this is valid more or less for the Canadian Cardiovascular Society classification of exercise angina. It's not very different. Okay, you see this, the patient has class 2 dyspnea. DCG was like that. Who tell me about this ECG? I have to put somebody. Okay, I will go from the beginning, which will be Joachim.
Okay.
Yes, take the challenge.
So it is sinus rhythm. I think that's a P wave in lead
Yes.
2.
You're right.
Let me see here.
Actually, you have 3 rhythm leads downstairs. Otherwise, you have only morphology leads.
So the axis is not normal because it's positive in 1 and then negative in AVF.
Indeed. It's about minus 60 deviation. Yes.
The heart rate is about 60.
It's below 60. If you calculate, I don't know, it's
It's right.
50 something, 54. something like that.
It's bradycardic.
Indeed.
And then in V5, you have the QRS complex is Can you hear me?
Yes, but you don't tell anything. Yes, is how much is the QRS complex?
I think it's five squares about.
Yes,
Small squares. So wide.
yes, maybe not 5, but at least 4. Yes, it's wide. Very good.
Yes.
I waited for tell me.
And then in V5, you have inverted T waves.
Indeed. V5, V6, yes.
Yes. So let me see what else. Is it and then because is it a left bundle branch block?
Indeed. That's what I know. It's a left band branch block. And when you have a left band branch block, it's difficult to judge the presence of Q wave. And for this reason, you are not sure about an acute myocardial infarction only if you consider the ST and T changes, but has to be important changes. These are only mild. I don't know if the patient indeed has a myocardial infarction 3 months ago, because when you have these left band branch block, is difficult to judge. Okay, good. This is the chest X-ray. Joachim, can you tell me something more about the chest X-ray? You already have radiology or not?
No, we have not.
Do you know something, or it's completely strange for you?
I can try.
Yeah, please try. I will help you.
So I would say that the heart is enlarged because of the angle at the bottom, right?
Because of the angle of the bottom? Yeah, it's enlarged. Very, very nice.
And then
I will help you. There is a special, we call it cardiothoracic index. That
yes,
means
that's what I meant.
you know already. Yes, it's you divided these the heart diameter and over the thoracic diameter. If it's more than 50%, it's obvious here, means it's a heart enlargement. Okay, good.
And then I don't know, but it might look like there's some pulmonary congestion.
Yes, it is. It is a lot of pulmonary congestion because the vessels are more visible in the upper lobes, which is not normal, and the highly are enlarged.
And then I really don't know more than that, to be honest.
Okay, I will help you. Usually, when you have a chest X-ray, you have to describe the heart opacity like that. There are 3 arches on the left side. This is the inferior arch, this is the middle arch, this is the upper arch, and 2 arches on the right side. This is the inferior arch, and this is the upper arch. Okay, and when you have we have to describe something about the heart in radiology, we have to take every arch and to describe. For instance, in this case, the most enlarged is the lower left arch, which usually is because the left ventricle enlargement. Okay, usually the middle arch is concave. This is the normal state, to be concave. But now it's convex, you see here, and these mean enlargement of the pulmonary artery, which is projected here. And the upper arch is because of the the aorta, but it's normal here. The lower arch is because the right heart, usually the right ventricle, but sometimes the right atrium, it's, you cannot tell too much about it, but the upper arch is because the ascending aorta, and it's obvious enlarged, usually has to be like that, but this is enlarged. Okay, good. Let's go to the echo. Echo show a lot of things. Oh, I forgot to put a back here. LV dysfunction, ejection fraction 30%. LV dilation usually has to be about 58 or something like that. But this is the diameter is enlarged. Dilation of the ascending aorta. Here is the left ventricle. This is the left atrium, and this is the aorta, the ascending aorta. In this view, it's parasternal view. It is called subvalvular aortic stenosis, which is this one with the blue crosses here. It's a measurement. It's a diaphragm below the aortic valve, which is this one, which made a stenosis at the ejection of the blood from the heart. And what we see that the valve is thickened, the valves, the aortic valve, and we don't see in a static photo, but we see during movement that is not open. This is the maximum opening. That means is aortic stenosis even at the valvular area, not only subvalvular, but valvular as well. And there is aortic regurgitation we don't see here, which is explaining the diastolic murmur, and pulmonary hypertension, which is explaining this bulging of pulmonary artery. Okay, but the coronary artery are normal. We don't see that well. This one, but it's normal. It was described, but normal. But this, the right coronary artery, we see very well in this normal. What to do? We have to operate this patient because this patient has an aortic valve and subvalve stenosis and has dilation of ascending aorta. If it's more than 50 millimeters, the ascending aorta, when you change the valve for aortic stenosis or aortic regurgitation, you have to change the ascending aorta as well. Otherwise, will be a risk of aortic dissection. And I will show you in the operating room what's happened. This is the heart, and this is the ascending aorta, which is the